lecture covering physical disorders and health psychology. This essentially follows along with Chapter 9 in your textbook. We're going to talk a little bit about how psychological and social factors can influence your health in a variety of ways, or the health of others. Um, in the meantime, in the process of doing this, we're going to differentiate between two related fields in psychology, essentially health psychology and behavioral medicine. So we'll talk about how those are different from one another and what roles psychologists play in those various disciplines. We're going to talk about the relationships between things like the immune system, stress, and how it can impact your physical health. And then we're going to talk a little bit about the role of stress in a few specific conditions like HIV and AIDS, cancer, and coronary heart disease. And then finally, we're going to talk about how do psychologists intervene to assist patients or individuals that are struggling with these issues. So how do we utilize things like stress management and prevention programs to try and help people to experience less distress and less impaired functioning as a result of their various health conditions? So professionally, I work in the area of behavioral medicine. So my job is as I've mentioned before, is in home-based primary care at the Salem VA Medical Center. So I work in a discipline that is much more applied. It's essentially a clinical position, and it really focuses on how we take information we've derived from psychology in general, behavioral science, and how we apply that to preventing, diagnosing, and treating a variety of medical problems. So it's essentially the world in which psychologists, clinical psychologists, are embedded within a medical field. They tend to be interdisciplinary teams where you work with other medical disciplines like physicians, physician's assistants, nurse practitioners, nurses, occupational therapists, dietitians, pharmacists, social workers. So really a team that has a whole bunch of different expertise in a variety of places to kind of work together. There's a distinction that's been made in this field for about the last 20 years. It was originally derived or described as multidisciplinary, and the difference was that multidisciplinary really talked about every discipline kind of stayed in their own silo. They were all sort of focused on one thing, and they contributed to an overall treatment plan, but they didn't really collaborate or cooperate very closely. They sort of just practiced or stayed in their lane. An interdisciplinary team is one in which those disciplines practice within their scope of clinical practice, but they also overlap in a variety of ways, and they collaborate a lot closer. There's a lot of emphasis on communication and building a treatment plan together with the input of all these various disciplines. So, for example, as a psychologist, while I'm focused on the patient's mental health, I'm going to ask a lot of questions about their physical health. I'm going to ask them about things like how they're managing pain, how they're sleeping, how their appetite is, how they're dealing with things as, indiscreet things you don't probably want to talk about, GI function, all these things. And so really assessing their medical functioning alongside with their mental health functioning. At the same time, the nurses on my team will ask some screening measures related to mental health, about suicidality, about depression or PTSD symptoms. They will do some, the people that are the primary care providers, whether they're physicians, nurse practitioners, or PAs, they will be doing some cognitive assessment screening measures. They'll be asking some screening measures about PTSD again, and depression and substance abuse and things like that. So our worlds overlap a fair amount, and we really work closely together. There's a lot of communication. And so it's really an applied interdisciplinary team in the medical setting in most cases. Health psychology is really a focus on what are the psychological factors that promote and maintain health, as well as how do healthcare systems and health policy affect people's health. So in one sense, it's more academic, it's more macroeconomic, if you will. It looks at sort of the larger systems, maybe more than the more applied behavioral medicine field does. I've seen plenty of people, though, that use these terms in an interchangeable fashion, but we do want to distinguish them from one another. Health psychology tends to focus more on research, and there's also a dichotomy you can think about. If you go to the general history of psychology, there's a lot of emphasis on the things we're studying in this class, on clinical conditions, on disorder, right, on abnormal psychology. There's a revolution that happens in psychology in the middle of the 20th century, really in the last 40 to 50 years, of what's called positive psychology, which was really started by Martin Seligman and a few other researchers. But there was an intense emphasis to shift focus from what causes people to develop problems and to experience distress and have impairment in their functioning. So rather than focusing on the, arguably the minority that's struggling, why don't we focus on people who are excelling, people that are doing well? What are the things that help people to be more resilient or to cope with normal stress and other issues in their life? So it was really a change in emphasis, a shift in focus. And I think health psychology is really more associated with the positive psychology movement, whereas behavioral medicine is typically dealing with patients that have at least medical diagnoses. In my patient population, they tend to be very medically complex and quite elderly and quite fragile in a lot of ways. But regardless, the people that you're treating are going to have some sort of medical and/or mental health conditions that we would consider, part of the focus of abnormal psychology. So that's an important distinction. And we're going to talk about how health psychology drives a lot of the research that's discussed in this chapter. So, what are the psychological and social factors that influence our physical health, our physiological health? We do know from lots and lots of established research that psychological, behavioral, and aspects of your social life, your social functioning, they contribute and can potentially cause certain medical disorders. They can exacerbate existing medical disorders. They can cause medical disorders to worsen and evolve into more serious conditions. And there's a few pathways how this can work. First and foremost, I guess one thing that's overlooked a little bit in this chapter is genetic influence, right? So we know there is some genetic influence that's going to influence your psychological and behavioral functioning, which will then come back and affect your physical health. So there is some circularity and some interaction between the biological perspective. But again, to focus on the psychological, behavioral, and social aspects, we look at these two primary paths. One is that psychological factors can influence the biological processes. So this is things that increase your risk for developing a physical disease. And this is very behavioral in a lot of ways. So we know that there are certain types of risky behaviors that put you at risk for developing certain types of physical disorders. Certainly smoking is a very kind of classic example, as it contributes to a lot of factors like coronary artery disease, cardiopulmonary functioning, respiratory issues, diabetes. There's even, of course, cancer, obviously. So there's a whole number of factors that are influenced by that behavior pattern that increases your risk for a lot of medical conditions. So that's an example of how your psychology and your behavior is therefore having a significant impact on your physical health. The example that your book discusses is the one of genital herpes, right? So this is a viral infection, a sexually transmitted disease, and we know that sexual behavior affects the chance of contracting the virus. Most importantly in the current context, lack of condom usage increases your risk, and of course, multiple sexual partners or any kind of other risky sexual behaviors. Again, this is a value-based judgment, so I'm not trying to allude to that, but more importantly, there are certain types of behavioral patterns that do increase your risk, especially not using condoms or other forms of protection from sexually transmitted diseases. So that sexual behavior affects your chance of contracting the virus. That's sort of a behavioral factor, but then psychologically, once you have contracted genital herpes or oral herpes, it's very similar viruses. The idea is that it's very common to have outbreaks, on average about 4 times a year, or sometimes more often, sometimes less. But we absolutely know from research that those outbreaks are influenced by psychological stress. So the likelihood of having an outbreak of genital or oral herpes is directly, correlated with the amount of stress that you're undergoing at that time. So these are all some various ways in which these non-biological factors can really come in and influence our biology. Let's talk a little bit about the evolution of health problems amongst human beings, at least in the United States, over the last 100 years or so. So this is just a list of the leading causes of death in 1900 and in 2010. So before we even delve into this, let's take a couple of important caveats into mind. First and foremost, the fact that the record-keeping, diagnosis, understanding of biology and medicine, all of these factors are different, of course, in 1900 than they are in 2010. So we need to consider that that this is not necessarily apples and oranges, but that there is some important concessions we need to make. There are some, some important concessions we need to make. That being said, let's go through this. So these are the leading causes of death in the United States at these two various times. In 1900, 11.5%, 11.8% of deaths were caused by pneumonia and influenza. Tuberculosis was 11.3%. Diarrhea, enteritis, and ulcers, so like lower GI disorders, 8.3%. Heart disease, 8%. Intracranial lesions of vascular origin. This is generally, you think of stroke or other illnesses like meningitis that attack the brain, 6.2%. Kidney disease, which is also referred to in 2010 list as nephritis. There's a couple of technical terms involved there, but essentially kidney malfunction, kidney breakdown of functioning, which is usually, chronic kidney disease is usually rated on our rating system of stage 1, 2, 3, 4, 5. We typically associate stage 5 with needing hemodialysis in the modern era. Accidents, so of course, unintentional physical harm, 4%. Cancer and tumors, 3.7% in 1900. Senility, which is an old-fashioned term for dementia, 2.9%. So all the various things that are under the umbrella of dementia, including Alzheimer's disease, but also other conditions. Diphtheria, 2.3%, and other, 36.1%. So the first thing I want you to notice is that on this list, 36.1 is by far the largest percentage of other. And I think we have to attribute that to a number of factors. Most importantly, the evolution of medicine over this 110-year period. There's probably a fair number of things that were not appropriately recognized or listed as the cause of death, for example. So that's our 1900 list. We jumped to 2010, but let's think about the major changes that have happened. A couple of very important things have happened. First and foremost, perhaps, is the development of antibiotics and a better understanding of germ theory and hygiene in a medical setting. So lots and lots of people no longer dying of sepsis and infection because of the evolution of our understanding of germs and how that works within the body. So if you think of 1864 or Civil War, people performing amputations of limbs in field hospitals in completely unsterile environments, maybe wearing a mask, probably not. Utilizing instruments that are not sterilized. All these things we think of as sort of the bad old days of Western medicine. By 2010, we of course have a very different understanding. So that's going to have a massive impact on a couple of things. People that are able to survive surgical and other medical interventions, people that don't die from infections that are secondary to other conditions because we can treat them with antibiotics, and of course a whole host of bacterial diseases that we can treat with antibiotics. The other major factor to consider is longevity. The life expectancy has expanded, statistically on a massive scale from 1900 to 2010. Again, the development of vaccines and antibiotics and understanding of a lot of other aspects of medicine means a lot of children are not dying in that first 1 to 3, 1 to 5 year range. It was very, very common in 1900 for families to potentially, on purpose in some cases, have twice as many children as they expect to raise to adulthood because statistically that was a fair bet. Lots of people, human beings throughout human history until the very recent era that we're all living in, died as very young children, if not infants. So that's a massive change, and that contributes, along with all the other innovations in medicine, diet, all these other things we understand about how the body works by 2010, to significantly longer life expectancy. Now, what that means is that you're not dying of these preventable illnesses like infections or diarrhea, which is caused by bacterial GI infections or parasites related to unclean drinking water, for example. But you are living long enough to develop illnesses that otherwise were not taking up a big piece of the pie in 1900. Things like cancer and tumors and senility, aka dementia. These are things that if you live long enough, the likelihood of your developing them becomes significantly higher. Heart disease, of course, is associated with a number of factors, but also longevity. If you live long enough and the cardiac muscle and other aspects of your cardiopulmonary functioning are not doing as well as they were, you're more likely to develop these illnesses. So heart disease jumps to the top of the list by 2010. again, I think that's really directly related and to a couple of major factors, one of which is the increased longevity. More people are living to the point where they essentially die of heart failure or something related to cardiac functioning. Um, Cancer has shot up the list again. A lot of cancers are more common as you get older. There are some cancers, of course, that are much more common when you're younger, like testicular cancer in men, and certain forms of lymphoma. But ultimately, a lot of the cancers that end up killing people tend to occur as you get older. Stroke, again, you live to a certain age, breakdown of vascular functioning, it's more prone to that. Here it's listed as Alzheimer's. I think I always take that with a grain of salt. To give you a very kind of dark sort of not mnemonic device, but a way of remembering is that there is one way to definitively diagnose someone with Alzheimer's, and that is changing. I'll put an asterisk next to that because there's a few new developments. But with the basic technology available today, the only way to definitively diagnose someone with Alzheimer's disease, that specific form of dementia, is through autopsy, is through examining their brain after they are deceased, because there are very specific patterns of plaques and tangles of neurons in the brain that we associate with the Alzheimer's disease, so to speak. There are lots of other types of dementia. There's vascular dementias, frontotemporal dementias, Lewy body dementias. There's a whole host of other ones that are involved. Alzheimer's happens to be the most common. On lists like this, in common parlance and a lot of sort of things that are intended for general public consumption, people will often use the term Alzheimer's to mean all dementias. So just keep that in mind. Diabetes, again, a disease that you're more likely to develop as you get older. Nephritis, of course, and then influenza and pneumonia now have moved down the list quite a bit. They are accounting for only about 2% of deaths at this point. Heart disease, by the way, is almost a quarter, and cancer is also almost a quarter, 23.3% in this list. Suicide has made its way onto the top 10, which is interesting, meaning that 1900 there were a lot of other things that were more likely to kill you than yourself. I don't mean to be morbid, but that's just the reality of the situation. And the other has dropped to 25%, so a quarter of these, meaning that we're doing a better job probably of diagnosing as well. So this is just sort of an interesting sort of dichotomy we can perceive about how things have changed as far as the major health conditions that you face 120 years ago versus 10 years ago. So 50% of the leading causes of death in the United States are linked to behavioral patterns, what we've generally started referring to many years ago as lifestyle related issues. And that was one of the points I wanted to make about the previous changes in primary causes of death in the United States. I'm going to be, I'm working with data from your textbook, but from other sources that is focused very obviously Western centric on the US. Many of these things hold in other nations like in Europe as well. But I don't want you to assume that these perspectives are entirely accurate for the rest of the world. There are plenty of places where things like malaria are still very dangerous and cause a lot of deaths every year, and a lot of other preventable illnesses that are just due to lack of access to affordable healthcare in a lot of these places. But point being, smoking is obviously one thing that is a huge contributor to deaths in the United States. Smoking is on the decline. It's really kind of shocking to me, being the age that I am, remembering being a child and people being able to smoke virtually everywhere, that it was quite common, and the idea now that the levels of people smoking is going down and down and down. Now, of course, people are utilizing nicotine and tobacco in various other forms, which has its own risks, but smoking has gone down. The devolution of the Western diet and poor eating habits is a major factor contributing to a lot of different illnesses, especially heart disease and diabetes and stroke. Lack of exercise, sedentary lifestyles, technological advancements that don't require us to be as physically active is definitely a factor. And then the other leading cause, related to these deaths in the U.S. today are things like what's called insufficient injury control, failure to use seatbelts, failure to wear helmets on motorcycles, things of that nature. So let's talk a little bit about the idea of stress. Stress as a term has become so ubiquitous. We all use the word stress to denote what I think we generally understand to be mental stressors, excuse me, things in your life that are causing you distress, concern, anxiety, frustration, worry, that kind of thing. We know that stress under that terminology, increases your vulnerability for developing both physical and mental health problems. Now, you go back quite a ways to 1936, and there's a young Canadian scientist named Hans Selye. And Hans Selye basically was a research scientist who was looking at rodent research to examine and understand how the immune system was working. So he was injecting one group of rats with an immune suppressing agent, and he found that they were developing more ulcers and other physiological problems, generally displaying worse health. And he also saw some atrophy of the tissue and the cells associated with the immune system. But in his control group, remember, in a control group, a lot of times the procedure is the same, but the actual thing that's delivered is inert, is inactive. In this case, he was injecting another group of rats as a control with a saline solution, an essentially inert, non-reactive saline solution. And what he found was that those same rats were also developing these problems. If he had a no treatment control where he did not inject the rats with anything, they comparatively showed less of these problems. So he derived that the actual act of being injected was somehow playing a role in the contribution to the development of these physiological problems. He borrowed the term stress from engineering. We talk about metal fatigue and the stress placed on a bridge, for example. So he used the example of if you have a bridge that is built of metal or stone or whatever, or wood, and you have a heavy truck driving over that bridge, it's kind of confusing the way the language works, because we might refer to the reaction of the bridge to the weight of the heavy truck as stress. The metal is stressing, the timbers are stressing, but we might also refer to the truck itself as a stress upon the bridge. So there's confusion. In this class, typically if I use the term stress, I'm talking more about the reaction to the things in life that are causing that stress. We use the term stressor, or to refer to the things that are causing the stress. So, for example, something like a breakup of a relationship, or marital discord, occupational problems, economic instability, other various stressors in life. So he posited a system or a theory which was very theoretical and was not really based upon a lot of research. There's a lot of inference involved in this, and he was jumping to a lot of conclusions, but he called it general adaptation syndrome, and he basically said this was a theory of stress response. He said that when the body is initially under forms of stress, that it causes an alarm response, probably involving the autonomic nervous system, that fight or flight response we discussed in the context of panic. The idea that you're under stress, your body then experiences a degree of arousal and awareness of, I need to address this issue that's emerging. That leads to phase 2, which is resistance, the attempt to cope with the stress through a variety of techniques and ways of approaching it, resolving the practical problems, finding ways to disconnect from the stress, to relax, other ways of healthy coping. However, if that stress is chronic, if it is of such a degree or severity that you are not able to effectively cope with it, we then talk about phase 3, which is exhaustion, where the body starts to suffer damage. And this is the phase in which the psychological stress, the situational, interpersonal, whatever it is, stress, is now leading to an exhaustion of the body's ability to cope, and increasing the likelihood of developing physiological problems. So this is the mind-body connection, essentially, that's such a point of contention within our understanding of how our bodies work. So there is a physiology of stress. We know that when you are undergoing things that we all generally agree would meet that definition of, stressor that's causing stress, it again ties into this system we've discussed, this HPA axis, the hypothalamic pituitary adrenocortical axis, or HPA axis. Okay, so a part of the brain in the midbrain that then can lead to the hypothalamus releasing corticotropin releasing factor, CRF, and this stimulates the pituitary gland. So all of these parts of our endocrine system and our brainstem and our midbrain are now being activated. The pituitary gland activates the adrenal gland, which secretes cortisol. And cortisol is understood in the body to be a stress hormone. It is a physiological indicator of things like stress, anxiety, depression. You can measure levels of cortisol in a variety of ways, including some blood tests, certainly through spinal tap and things like that. But the idea is that this is a hormone that your body releases when you're under stress. And ordinarily, the hippocampus, another aspect of your midbrain, sort of the part of a brain that bridges between the sort of the forebrain and the midbrain, will turn off the stress response. But we know that the hippocampus and its ability to do that, to inhibit that stress response, to like turn the volume down on the knob, so to speak, to allow you to cope and adapt and relax, it can be damaged when it's overtaxed. And it can be overtaxed either in a chronic fashion, maybe relatively low or even moderate levels of stress, but lots and lots of it over a long period of time, or spikes, intense periods of incredible stress, things like combat, sexual assault, physical assault, things that are very much life and death situations, a horrible accident, motor vehicle accidents, things like that. So these factors can damage the functioning of the hippocampus. So you've got, again, the psychological, behavioral experience of what's happening between you and the world as you interact, having an impact on the physiology of the brain. What are the contributions to the stress response? How do we get, how much of a reaction do we get? How strong is it when we are undergoing stress? There's some primate research, which is really interesting, looks at social factors. So in a lot of primates, there are very extreme hierarchical structures. In some they're patriarchal, and others they're matriarchal. But essentially, there are dominant or alpha, animals, and then there are subordinate animals, and they're very hierarchical, very steep, narrow pyramids. And so a large portion of the members of that social unit are in a position of subservience. And we know that subordinate animals tend to have chronically high levels of stress, which you can measure through things like cortisol. And this compromises their ability to respond to stress effectively over time, and also leads to compromised immune system. So there's a benefit of high social status. There's a predictability, there's a controllability of the environment when you have power in an environment. And this is really kind of fascinating because in some ways, not only is that individual's experience less aversive, less difficult, they are more likely to be healthy, and those that are undergoing stress that are subordinate are more likely to be unhealthy, and in a evolutionary perspective, maybe less likely to pass on their genetic material and therefore be selected through the process of evolution. So this all plays out in a much larger context. Going back to some of this research, this informs our understanding of how stress is experienced by individuals and how it manifests itself, what the reaction looks like. So we know that if you have a low sense of controllability or in your ability to cope, then you are more likely to experience stress in the form of depression or anxiety. If you think about some concepts we've discussed in this class already, locus of control, okay, a dichotomy, a continuum of your belief in your ability to control the world around you or to control your own experience. If you have an internal locus of control, then you believe that you are able to exert influence. If you have an external locus of control, then external factors are responsible, and therefore you are, at the extreme, essentially helpless. Of course, it exists along a continuum, as you see here. The other, when you think about your ability to cope, this is tied to a construct that comes from Albert Bandura in the cognitive behavioral world, and he talks about the idea of self-efficacy. And self-efficacy is a little different than self-esteem or self-image. Self-efficacy is your belief in your ability to exert influence or control over your environment. So as you have less sense of control, whether it's external locus of control, as you have less self-efficacy, you're more likely to experience stress or respond to stressors, I should say, in the form of depression or anxiety. As you have increasing ability to cope, under a belief in your ability to cope or sense of control, you experience it as stress, and at the really extreme end of that continuum, you may experience it as excitement or arousal. And you can certainly think of people we refer to as adrenaline junkies, right? People who thrive in high stress environments or jobs, or people who perform at very high levels of sport where, it's very intensive and demanding and requires a huge amount of, intense energy to be expanded in a certain setting. So all these factors lead to an interplay between how much of the stressor is present in the environment, how much stress is the person undergoing, so to speak, and then what form that reaction will take is really dictated by their psychology, by the structure of their psyche. So this stress has an impact on our immune system, our immune response. The higher we are, the more stress that we're under, we know that it affects our immune system functioning. So the intensity of stress and negative affect is actually linked to things like the development of the common cold. There is some really interesting research in your book where they talk about people essentially, signing an informed consent to be exposed to the cold virus. And of course, in an experiment, you're randomly assigned to one condition or the other. In one condition, of course, you are, going to be, in all conditions, perhaps you're going to be exposed, but we're also going to measure the levels of stress that you've been under for a significant period of time preceding that exposure. And what you find, interestingly enough, is that people that are under less stress, people that are experiencing less depression, less anxiety, are less likely to contract a cold, and the severity of the cold is likely to be less if they are in that sort of on that side of the continuum. The degree of your sociability, like how much you engage with others in social settings, can seem to influence the likelihood of contracting a cold. We think this is probably due to healthy coping. If you're engaged socially, that's one form of coping with stress, is social connection, meaningful social interactions and relationships, then perhaps you are experiencing less stress, you're coping more effectively. So the research on the impact of stress on the immune system is very robust. Things like marital discord, the loss of a job, the death of a loved one, meeting the diagnostic criteria for depression, all of these factors can significantly impact your immune system and make you more prone to getting sick. And when you do get sick, to getting sicker and to having a worse course and a worse experience with that illness. Something as simple, I shouldn't say as simple, something as distant as early life stress can contribute to how your body expresses inflammation in adulthood. And there's more and more research on how inflammation plays a really important role in a whole host of illnesses and how we feel. This has led to a new study in psychology, which is a mouthful, psychoneuroimmunology, which is really looking at the psychological influences on the neurological component of the immune response. So how do our experiences, how does our psychology, our thinking, our cognition, how does that affect our actual neurological functioning, the actual physiological level, concrete level functioning of our brains, of our bodies, and our immune systems? So for example, there are some studies where you give rats are injected with or given orally sugar water mixed together with a drug that suppresses their immune system. There's a simple conditioning process, an associative process taking place here, a behavioral process. And what they find, strangely enough, is even though, of course, the rat has no conscious understanding that it's being given one or the other, they found that sugar water alone could then suppress the immune response once they had been conditioned and associated those two stimuli. This is a strict behavioral intervention leading to a change in the neurobiology of the functioning of the immune system, which is not always a way that we expected, a direction we expected that arrow to run. It was always sort of understood that biology had such a powerful influence on our psychology. But what we're discovering as time goes on is that this is a two-way street, that it is an interactive model. And so these two things influence each other in a very collaborative and dynamic way. So what does our immune system do? Just to kind of give you a very, very brief overview of this idea. So our immune system is really the part of our bodies that is intended to identify and eliminate foreign materials, which are called antigens. So really a foreign material can be any number of things. Certainly viruses, bacteria, parasites, cancers, these are all foreign materials or antigens in our body. And there are two basic processes of our immune system, what are called the humoral and the cellular. This distinction, there's a lot of interaction across these two systems, so I don't want you to worry too much about fully understanding why this distinction exists, just that it does. So part of this includes on the cellular level, you have things like white blood cells or your leukocytes, which are essentially the aspects of your immune system that attack various antigens in the body. And so B cells, T cells, macrophages. Now the B cells are essentially associated with what's called the humoral response. And this is really the idea of going in. These are cells that go in and neutralize antigens in the blood and in other bodily fluids. The T cells are there to attack antigens in various ways. They're sort of like the foot soldiers of this system. And macrophages are the structures that are utilized to do so. But this is an interactive system. We're going to look at a diagram here in a moment that really details how these things work together. But essentially, what we found is that the immune system is there to get rid of things that are dangerous to your body in a variety of ways, but it does not always function as it should. And in some cases, you can have examples of where the immune system becomes too active, too overactive, and may attack your body's own cells. For example, rheumatoid arthritis is a condition where the T cells start to attack normal, healthy cells, and can cause a lot of neuromuscular damage, a lot of neurological problems. On the flip side of that, what we've learned is that we can actually harness and utilize the immune system to treat various illnesses. And this is a very young and quickly developing field of immunotherapy. So there are some treatments for cancer that are becoming very, widespread today that involve engineering anti-cancer viruses. So we're taking viruses that are already pre-existing in nature and we are genetically and chemically modifying them so that they will then go and enter cancer cells. They're essentially bonding with the cancer cell as viruses. Our body recognizes those viruses and then stimulates our immune system to destroy those cancer cells throughout the body because they carry that recognition of having a virus present in them. So you're sort of ramping up the existing immune system. In interesting ways, this sometimes runs a little counter to the concept of chemotherapy, which is essentially, for lack of a better term, chemotherapy, as targeted as it is introducing toxicity. It's trying to kill cells, but it's trying to target cancer cells. In the process, the problem with chemotherapy, which is getting better but is still a major issue, is that it's sometimes a kind of blunt instrument and it destroys other healthy cells as well and causes all of the problems that chemotherapy can. It can depress the immune system quite a bit. Immunotherapy is in many ways the other side of the coin. It's trying to ramp up and amplify the body's immune system to harness it in some clever ways to fight things like cancer cells. This is a diagram that helps you to kind of understand how that humoral and cellular system of the immune response works. So the macrophages are the first line of defense that are there to attack and break down antigens in the body. The cellular branch involves T cells, of which there are a variety. And one aspect of these T cells are memory cells, whose job it is to spread future anti-germ destruction. The idea being that this is sort of your body learning from the experience of having been exposed to an antigen. It's like, okay, I now recognize this antigen. When I see it again, I recognize it as a threat, and I'll be even more effective at attacking it. This is how we build up antibodies, so to speak. Then there is one subtype that are called the killer T cells, which are really sort of the tip of the spear that go and attack and destroy the antigens. Now, these T cells also work to trigger the humoral branch of the immune system, which involves things like B cells, which produce antibodies, which then go in and neutralize the antigen rather than destroying them. So these are just two ways of approaching attacking or removing or neutralizing things that cause us to get sick. And they also have a process of what are called memory B cells, which speeds future antigen neutralization. So again, this is your body's immune system's memory of what it's been through. It gathers information, creates a file of recognition so that when you're exposed to that antigen again, you may never even be aware of it, or of course you may just do a better job of resisting it and fighting it off. Disease susceptibility is really related to this process of our immune system. So you may have a psychological characteristic or state which contributes to the way your neurobiology functions in terms of your hormonal response. You may be behaving in ways which make you more susceptible to a particular disease. For example, smoking. The process of how your central nervous system functions. All of this leads to immune change, which can make you more susceptible to contracting or developing a more serious form of a disease. So let's take a few examples now of how this process works and this interplay between psychology and physiology. And what I hope you take away from some of these examples is how psychologists are involved in the medical world and helping people to cope with medical illnesses, not just the things we typically associate with abnormal psychology. So a quick review. Basically, when we talk about AIDS or acquired immunodeficiency syndrome, we're talking about a condition or a syndrome which is caused by the HIV virus. And the HIV virus has some interesting characteristics about that differentiate it from a lot of other viruses that we really have been exposed to before its development, its evolution, before it really became something we were painfully aware of, especially in the early 1980s, although it was detected earlier than that. Anyway, the HIV virus can be dormant for significant periods of time, for years after you're infected, and it eventually leads to what's called the AIDS-related complex, which is some minor symptoms that begin to emerge in the body. So being HIV positive, as many of you already know, means simply that you carry that virus within your bloodstream. AIDS is when that virus begins to manifest itself in a number of symptoms, and this complex can include things like weight loss, fever, and a depression of the immune system. So it may take decades to process or to progress from an HIV positive infection to full-blown AIDS, which is where the illness becomes quite serious and has, in the absence of modern treatment, has a very high mortality rate in many cases. So most people in the developing world, unfortunately, die within 1 year of developing symptoms of the actual AIDS syndrome. I shouldn't say AIDS syndrome, but of AIDS. What's changed in recent years is the slow but albeit effective development of treatments, mostly what's called highly active antiretroviral therapy, or HAART treatments. This is not a cure for AIDS or HIV, but it essentially is a medication that can be taken on a chronic basis to significantly tamp down and either completely stall or delay the development of AIDS, despite being HIV positive. It can also significantly decrease the individual's potential to transmit HIV to other people while they're undergoing these therapies. It is not a panacea. It will not completely eliminate that risk, of course, but it does decrease it significantly. So it has a two-pronged approach of addressing the virus, both on a micro and macro level. These medications have gotten better, and they have been around for some time, but I'm sure many of you have heard of the HIV cocktail, which is often a combination of a number of different antiretroviral medications, which are all taken in a variety of dosages. Now, what's really fascinating is we are seeing some research now. The very same mechanism of delivery for the Pfizer and Moderna vaccines for COVID-19, this messenger RNA approach, which is not a new approach to vaccinations. It is something that's been developed for well over 10 years. COVID-19 was the first major application of the mRNA approach to vaccination, and it is very different from all other techniques we've utilized in medicine to vaccinate people in the past. It has incredible implications for a lot of different illnesses, and on the very top of that list, along with COVID-19, is HIV. So we're talking about a vaccine against HIV, a vaccination that could be given to individuals who have not been exposed to HIV, that would essentially protect them from contracting the illness and therefore from ever developing AIDS. So there are some things on the horizon, and they are not yet here, but there is some very promising research regarding our ability to essentially eliminate the spread of HIV, and then potentially with enough coverage of that vaccination and effective enough vaccinations, we could potentially eliminate it the way we've there's been a massive movement to try and eliminate polio, for example. This is an image from your book that talks about the prevalence of AIDS. So you go to to 1990. There's about 9.1 million people living with HIV. By 2011, it's reached 34 million. Basically, the donor governments, there's massive amounts of funding into research of AIDS, but certainly not enough. The United States funding for HIV/AIDS accounts to less than 1% of the U.S. federal budget. And as you can see from this map here in the middle of this image, because of the antiretrovirals, because of the availability of condoms and education about HIV transmission, in a lot of places in the West, these numbers have become less and less prevalent. But in a lot of other parts of the world, in what's commonly referred to as the developing world, which is a controversial term, I understand, but in places like sub-Saharan Africa, in parts of Asia, these numbers remain far too high. And there is also a socioeconomic and a related racial aspect of the rates of new HIV diagnosis. 62% of new HIV diagnoses in 2010 were in African Americans. And the same is true. These increasing numbers are seen for Latinos, for Native Pacific Islanders. And essentially what you find is that there's an association between socioeconomic status and the related ills, unfortunately, of systemic racism that mean that HIV is disproportionately present in these populations. So HIV is something that has evolved. Our awareness of it has gone through a process of increasing and decreasing incrementally over many years. It remains a very serious problem for much of the world, and there's a role for psychologists to play in people that are living with HIV and AIDS. In the United States, about 50% of HIV transmission is still from male to male sexual contact, about a third from heterosexual contact, and about 17% from injection drug use. Other, basically is for accidental exposure to blood in certain settings, especially medical settings, law enforcement, things like that. And occasionally we will still see some transmission through blood transfusion, but that has become extremely rare. Whereas in the early days of the HIV crisis, people who suffer from hemophilia, people that required blood transfusions for accidents or illnesses, were contracting AIDS because of proper screening and testing of blood samples. So, inarguably, HIV is a virus and AIDS is a medical syndrome associated with that virus. But we know that there is an interplay between psychosocial factors and AIDS or HIV. So AIDS progresses faster under higher levels of stress. Individuals with lower amounts of social support, so lack of a social support network, people who are socially isolated or alienated or maltreated in many cases, show more rapid progression of AIDS. So the goals within treatment of AIDS that's holistic, that's not just looking at things like medication and measuring labs, is to reduce stress and to therefore boost the immune system. This is a really important aspect of helping people to stay healthier longer. You see increased T helper cells, which are important in fighting the HIV virus and keeping it from becoming AIDS. Lower antibodies, enhanced psychological adjustment. All of these things are really factors where we can help the individual from a mental health perspective, but exercise a significant impact on their physical health as well. So there have been some interesting research conducted on how psychological interventions can help with HIV and AIDS. So there's randomized controlled trials, which if you remember is sort of the gold standard in research methodology for an experiment. And they've examined the efficacy of psychological interventions on neuroendocrine hormone regulation. Again, that's part of that HPA axis and how we handle stress hormones in our brains and in our bodies, and the immune systems in HIV positive individuals. So there is little support for the differential efficacy of different interventions, let me break that down for a moment. What's interesting about that is it seems that there is no magic bullet. There's no one intervention that is far more effective than the others. It seems to be that a little support goes a long way, that various types of psychological interventions seem to have comparable positive impact on people's functioning who are living with HIV and AIDS. The treatments that are successful in improving psychological adjustment, so addressing things like anxiety, depression, stress, interpersonal difficulties, they're more likely to have a beneficial effect on neuroendocrine regulation and on the person's immune status. Because ultimately, in a lot of ways, when you are living with HIV, I don't mean to be flippant about this, you live and die by your immune system. If you have a very strong immune system, or if you're doing things to maximize that immune system, you're essentially keeping HIV largely dormant. You're keeping it from manifesting in the most dangerous ways that it can. So anything that can be done to maximize the immune system has potential to prolong or save that person's life. Let's shift gears from HIV and talk a little bit about the role of behavioral medicine and health psychology on cancer. So if you remember from our slide about the causes of death, of course, cancer accounts for about a quarter of all deaths in the U.S. The field of psycho-oncology is really the study of how psychology and cognition affects various factors in cancer. And having worked in palliative care and hospice quite a bit, there is lots and lots of research on how psychological interventions, social interventions impact a person's process of hopefully surviving cancer, living with cancer, or of hopefully being cured of cancer in some cases. So we know that psychological behavioral interventions contribute to the etiology and the maintenance of cancer as well. So there are risk factors psychologically for the development and then the worsening or maintaining of cancers. Perceived lack of control. Again, we're back to this sense of self-efficacy and locus of control. People who have poor coping responses, so people that try to stuff things down through denial and don't confront or deal with stress, tend to do worse in regards to the course of cancer. Of course, undergoing stressful life events, unfortunately, increases your potential risks. And certain lifestyle risk behaviors, of course, are psychological and, more importantly, behavioral contributions to cancers, most obviously smoking and other types of substance abuse, and unhealthy habits regarding eating and sleep and other factors. So the mechanism of cancer that we're depicting here is how psychological factors impact your cancer risk through a variety of avenues. Your immune function, your viral activity, the process by which your DNA is able to repair itself when it is damaged when attacked by cancer cells, and how those genes are expressed. So we don't understand cancer as a whole. I think an important thing to keep in mind is that cancer is a umbrella term for what's essentially at best thousands of various different types of illnesses. That's why when we talk about a cure for cancer, you're referring to something pretty dramatic and global in our understanding and our ability to interact with cells and genes in the body. But we certainly talk about types of cancer and mechanisms of how they work in their body, and what are the risk factors and things that can make them worse or decrease your prognosis, make it worse. There are a number of interventions that psychologists are involved in, and other mental health professionals in cancer centers and working with cancer patients. We often refer to these as psychosocial treatments because they really address the individual's psychology and their social environment. We can help people to improve their health habits, which of course improves their immune system. We can help them to adhere to the treatment plan more effectively, so not to skip appointments, to take their medication as prescribed, to follow instructions regarding things like chemotherapy and radiation. And then we see improvement in endocrine function through psychosocial intervention. And of course, training and education in how to cope with stress is a big piece of this. So the person's stress response and their ability to cope is improved through these interventions. This can lead to better remission and decreased mortality in cancer. So this is, again, the odd understanding of this being a two-way street, that we can intervene with the person in a psychological, social context, and we can have a real impact on how their body processes cancer cells. This is a figure from your book. There's a whole section in your book where it talks about psychological interventions with breast cancer patients. So in this original study listed in your book, there were 227 patients with breast cancer, and in the treatment group, they underwent stress reduction, coping skills for mood like depression and anxiety, and interventions to help them adhere to the treatment plan more effectively. And at the 11-year follow-up from treatment, what they saw was there was a significant drop of about 56% in mortality, and a drop of 45% in recurrence of the breast cancer. So some really dramatic impacts shown in this controlled study, controlled experimental design, where psychological interventions significantly improve outcomes for breast cancer sufferers. Let's move on to our third sort of major cause of death in the United States, cardiovascular health. This can include a whole host of things you might think of as stroke, hypertension, heart attack, high blood pressure as a risk factor, of course. This is really the interplay between our respiratory and our cardiovascular systems. that can cause a lot of these conditions. But ultimately, we're talking about your heart, your blood vessels, and the regulatory mechanisms that go along with them, both in the brain and other aspects of the nervous system. The problems we associate, as I said, are things like myocardial infarction or heart attack, hypertension, aka high blood pressure, stroke, which is also sometimes called a cerebrovascular accident, or CVA. There's a heightened responsivity to acute mental stress that has adverse effects on cardiovascular health. We know that how you cope with stress, how you cope with aversive situations and conditions in your life has a really significant, potentially negative impact on your cardiovascular health. This old adage amongst physicians and cardiologists that stress is a killer is maybe a little oversimplified, but certainly there is some smoke there if there's not fire. So chronic stress and personality factors are extremely important in how we experience cardiovascular health and functioning. So hypertension, aka high blood pressure, very common condition, and it increases your risk for a number of potentially lethal health conditions, specifically heart disease, which can lead to heart attack, stroke, other factors like that, pulmonary embolisms, all kinds of things, and then kidney disease. So your cardiovascular system, when it's not functioning well in terms of high blood pressure, can have some really significant impact on your renal function, which can then lead to kidney failure of varying degrees. Also, hypertension taxes the blood vessels. Our blood vessels are elastic and they are able to expand and contract a fair amount, but when they are overtaxed, they lose their resilience, they lose elasticity, they become more fragile, and so by that overstress through high blood pressure, what you're essentially doing is you're breaking down the mechanism by which the blood and therefore the oxygen is being delivered to the cells in your body, including your brain. Hypertension is quite common in more than a quarter of North Americans ages 35 to 64. There are some racial and socioeconomic factors at play here. We know that African Americans have 2 times a greater risk for hypertension than their Caucasian counterparts. Excessive salt or sodium intake is a major risk factor. Sympathetic arousal or having a highly reactive autonomic nervous system is a risk factor. Stress level, of course, degree of expressed anger, right? That's an interesting one. How much you sort of operate from a place of anger and irritability has a really significant impact as a risk factor for hypertension. And then hostility. So dwelling on sort of mistreatment and injustice in an unhealthy fashion, and being hostile and aggressive has some significant risks for developing hypertension as well. Now, we do know, of course, that there are some significant genetic risk factors for hypertension. Hypertension runs in my family. No amount of exercise might prevent me from having high blood pressure because of my genetics, but there are certainly a lot of psychological factors that influence the development of hypertension. So personality, coping style, and level of stress are these strong influences in a lot of research that seem to explain individual differences in high blood pressure. Social support is a very important contributor to cardiovascular health. This is a really fascinating, again, interaction between the environment and the biology, but having a good social support network, not being isolated or completely withdrawn from others, is contributing to your cardiovascular health. Feelings of loneliness, depression, uncontrollability, anxiety, these are all psychological factors that contribute to cardiovascular functioning, meaning they contribute to cardiovascular problems. And happiness and optimism are associated with cardiovascular health. And that's a bit abstract and philosophical, but we know that people that are displaying higher levels of satisfaction with their life and less depressed mood, aka happiness, and positivity about the future, less negativity about things within reason, are likely to experience better cardiovascular health and therefore lower levels of hypertension. Coronary heart disease, which is sometimes also referred to as coronary artery disease or CAD, is essentially blockages of arteries that are supplying blood to the heart muscle. So these are factors that essentially lead to things like heart attack or atrial fibrillation, things like that. Psychological and behavioral risk factors include stress, anxiety, anger, poor coping skills, and again, low social support. So we are social animals, it would seem. Now, this is not a hard and fast absolute rule. There are some individuals that do fine and thrive in relative isolation. This is a more of a law of averages across individuals. This is what we see as a trend amongst human beings. Um, Coronary heart disease is linked to a specific type or style of behavior, which is very typically referred to as type A. Type A behavior includes a lot of anger and hostility, very driven and competitive individuals, people who have a hard time with impatience or waiting. They're very restless. They tend to display accelerated speech. I can be guilty of this, I know. I don't think I'm entirely type A, but that's one characteristic I might have. And then certain types of agitated motor activity, people that are physically restless. And we know that coronary heart disease is also linked to things like chronic negative affect or depression, low socioeconomic status, and stressful experiences. So again, all environmental and social factors that impact your development of coronary heart disease. The type A issue is one that's been researched quite a bit and was very popular and very well studied, especially in the 80s. But essentially, it is more of a personality or way of approaching the world and functioning that seems to contribute to the increase of developing coronary heart disease. So again, this is a multidimensional model that looks at the interaction of a number of factors. So you've got the interplay between things like low socioeconomic status or SES. So decrease access to resources, decreased position in the social hierarchy, and I think most importantly, a lot of financial and otherwise survival insecurities, lack of access to reliable, healthy food and a lack of access to medical care or psychological care. Then you are engaged in threats of actual loss or harm or decreased potential for gain. And as a result, you have increased negative emotion and cognition, so negative thoughts about the world, the future, yourself, decreased positive emotion or joy, a positive experience, and decreased cognitive functioning as far as coping through cognitive means. And then you kind of get this interplay between these, which leads to a reverse capacity. You have difficulty with both interpersonal and intrapersonal functioning, and this all interplays to lead to an increased risk for a biological, physiological condition of arteriosclerosis, which is the buildup of plaque or blockages in the blood vessel, and therefore coronary heart disease. So a whole host of multidimensional factors that are not genetics, biology, diet necessarily, that are leading to the increase of a risk for a biological illness. A factor that is very prominent in the work that I do is chronic pain, by virtue of a geriatric practice and by virtue of working with patients who are very medically complex. Pain is an entire area of study within psychology. In fact, there is the field of pain psychology that looks specifically at this. Pain is, there's been a big push in medicine to refer to pain as the fifth vital sign, right? The idea that it is something that should always be assessed and measured. But the unfortunate problem with that admirable desire to make it something that we look at and we address and we try to manage is that it is not the same as the other vital signs. Blood pressure is a very objective, empirical measure of the amount of pressure within your blood vessels when your heart pumps and then when it contracts. Temperature is a very objective measurement of the basal body temperature, measured in a variety of ways. Respirations, number of respirations per minute. Again, these are all objective. Pain is not objective. It is inherently subjective. And so it is by its nature entangled with your psychology and your subjectivity and how you experience pain. I always use the example of imagine two young women who are very similar in a variety of ways demographically. They're both, let's say, 25 years old, and they're both in the emergency room late at night, and they're both having acute abdominal pain. One of them is 9 months pregnant. One of them is not pregnant at all. And the way that individual is going to rate and experience their pain is going to be different because in the context of someone who is 9 months pregnant, they have a context to understand the pain. They know what it's about. They know it's part of the normal process of perhaps contraction to begin labor. Whereas an individual who is not pregnant, this is going to be an unexplained, unexpected, potentially quite aversive and scary pain that they're experiencing. Not to say that childbirth pain cannot be scary, but at least there's a context and understanding of what it's about. Those individuals are likely to experience that pain very differently subjectively because of the context. So pain can manifest itself, of course, in a variety of ways. We talk a lot about acute versus chronic pain. There can be lots of things that about pain that affect our behavior. We might have issues with mobility, such as a limp, or require a walker or a wheelchair. We complaining, of course, is a behavior associated with pain. Letting others be aware of how much your pain hurts. Avoiding certain activities is a massive factor in my patient population. Many of them who are depressed or anxious, when you ask them why do you think you're depressed or anxious, they will say either I'm in a lot of pain or I am physically not able to do the things that I used to do that I enjoy, that are meaningful to me because of my pain or because of my mobility problems. And so these are the ways in which behavior is being impacted by pain. But as I mentioned, experience is highly influenced by psychological factors, how you experience the pain. If you go to the doctor these days, they're going to ask you to rate your pain on the pain scale, on a scale of 0 to 10, 0 being no pain at all, 10 being the most pain you can imagine or the most pain you've ever experienced. How would you rate your pain today? That's the way we measure it objectively. But it is not a perfect scale by any means. We can't utilize some Star Trek technology and just, wave something across your forehead the way we check your temperature and say, oh, your pain's at a 6 of 10, therefore I should give you this many milligrams of this pain medication. It's not objective that way. So severity of pain is not a good predictor of how someone's going to react or cope with it. So many of my patients struggle with chronic pain. And chronic pain, I think even more so than acute pain, interacts dynamically with your psychology. So acute pain is often pain experienced in a crisis. You've injured yourself, you have some underlying condition that's come to a head. Not that long ago, a couple of years ago, I had to have my gallbladder removed, and I'd been having some pretty bad pain for a matter of weeks that was initially, with good reason, misdiagnosed as something else, and then finally ended up in the emergency room with a severely enlarged gallbladder and had to have near emergent laparoscopic surgery to remove it. It's called a cholecystectomy, is the technical term for removal of the gallbladder, because I had gallstones that were blocking it and causing me really intense abdominal pain and causing my gallbladder to enlarge to about a third of its size. I'm sorry, about 3 times its normal size. That pain was acute. I was essentially at one point nearly delirious with pain. I was having a hard time focusing. Your body is pumping out a massive amount of endorphins. Your autonomic nervous system is just going off the rails. Panic is certainly a potential issue in that setting. That is a very different pain than the pain that people live with on a day-to-day basis, that they carry with them sometimes for years, for decades. That experience of pain changes and evolves and interacts with your psychology in a lot of powerful ways. And how you experience it, how bad or intense or subjectively how you experience that pain, is heavily influenced by things like your perceived control over it, and how you cope with pain, if you have skills or abilities or techniques that allow you to manage the pain on a psychological level, and how much social support you receive also, again, has a major influence on how you experience pain. So pain behaviors may be increased by some things, unfortunately, environmentally, paid time off, compensation. People might experience their pain because it allows them to manifest certain benefits. This is not to diminish or invalidate the pain of people. This is just a factor of how it's affected socially. And then social reinforcement. We might receive sympathy or attention when we experience pain, when we report pain. And for some people, that is an unmet need, and therefore influences how they report and experience that pain. Not even necessarily in a conscious way. I'm not talking about malingering, where you fake being ill, or overemphasizing your pain for secondary gain. It genuinely is part of a largely unconscious process in how you experience the pain because of these social factors sometimes. There are some psychological theories and mechanisms at play in how we think the brain processes pain, how it controls it, how it understands it. One is what's called the gate control theory of pain, which is a neurological process. Things like anxiety, fear, and intense concentration can affect the degree to which pain is detected. Essentially, that the mental process, the circumstances that are going on psychologically can really affect how you are able to detect and experience that pain. Our body essentially has what are called endogenous opioids. I'm sure you're all very familiar with the opiate crisis. So these are, synthetic and natural medications derived from the opium poppy, including everything from opium, heroin, and other illicit drugs, oxycodone, OxyContin, all these pharmaceutical drugs, fentanyl. They're essentially, all of these drugs are mimicking what are called endogenous opioids, naturally occurring pain reduction drugs, if you will, really neurochemicals in our brain that are pain inhibiting. And they can be increased in a lot of ways. People have talked about runner's highs and things that, this high we sometimes experience through exercise. What you're really doing is you're stimulating release of endogenous opioids. We know that the function of these mechanisms within women's bodies are somewhat different than they are within men's bodies. Females tend to have additional pain regulation mechanisms in their brain that likely evolved to facilitate childbirth. So there's a highly complex neurocognitive process going on in the brain. This is figure 9.13 from your book. But essentially this talks about all the aspects of the brain and how they interact in excitatory and inhibitory fashion. I won't expect you to get into the weeds too much on this for the purposes of this class, but I want you to understand how the various parts of the brain all interact and connect with one another in terms of processing and managing pain through the use of endogenous opioids. Another example of a physiological condition or disease illness process that is affected by psychological factors is what's called chronic fatigue syndrome. Now, chronic fatigue syndrome is a somewhat controversial diagnosis. There are certainly some practitioners that believe that chronic fatigue syndrome is essentially a somatic illness, that it's really it might even fall under what we might call somatoform disorders in some cases in the DSM. I think there's plenty of evidence this is not the case entirely. Of course, there are certainly examples of people who are somaticizing, if you will, psychological illness into the form of a physiological illness. But chronic fatigue syndrome is basically a syndrome, which is just a gathering of symptoms that tend to co-occur. But it's marked by a really intense lack of energy, intense fatigue that does not seem to improve even though the person is getting adequate sleep. They may have a lot of low-grade aches, pains, or low-grade fever even. It is more common in females than males, statistically speaking, and it is showing an increasing incidence rate in Western countries. And the reason why it's kind of come to the forefront is because, of course, from an economical perspective, people who are suffering from chronic fatigue syndrome, often it's severe enough that it significantly impacts their occupational functioning. So it becomes a drain on individuals and on society in some ways, and therefore gets a lot of attention, especially in the last 20 or 30 years. But it is a catch-all for a group of symptoms that I think it's fair to say is not entirely well understood, but we're going to talk a little bit about it because it is one of those conditions that does seem to respond to psychological intervention and therefore gets the attention of psychologists in both the research and the clinical worlds. There are a few other symptoms that are associated with chronic fatigue syndrome. Subjective memory impairment. Subjective meaning that the person does not necessarily score significantly worse than people without this condition on objective measures of cognition like the mini mental status exam, other batteries for neuropsychiatric status. but they report they feel forgetful and have a hard time remembering things. Sore throat chronically, tender lymph nodes, muscle pain, joint pain, headache, unrefreshing sleep, and malaise lasting more than 24 hours. Malaise is like kind of a catch-all term for generally not feeling well, very fatigued, very, just generally feeling ill. It's not too specific in terms of symptom presentation. We don't really know what causes chronic fatigue syndrome in some individuals and most individuals. There occasionally what will happen is you will actually diagnose an underlying medical condition like hypothyroidism, which therefore explains the chronic fatigue syndrome. But as a whole, there's not one known mechanism. There's no biological or viral cause that has been found, and it's believed that it may be a response to stress. And I say that with a grain of salt. I don't want to be implying that it is entirely a psychosomatic illness, if you will. But it does seem to have its origins in an interaction between the person's individual stress in their life and then how their body is processing that stress. Medications are generally ineffective in treating chronic fatigue syndrome, which is another reason why physicians often will point to the likelihood that it has a psychological cause. CBT, or cognitive behavioral therapy, if you remember from previous lectures, may be helpful. It includes a lot of emphasis on behavioral activation, which is like getting the person more physically active because of the neurochemical positive impact that has on the brain, regulating rest, and then implementing stress reduction and relaxation strategies. So there are some psychological factors that are pretty unique to chronic fatigue syndrome. There are some core negative cognitions or beliefs that one is inadequate, a lot of perfectionism. Using the word must or should is a good indicator that you might be on this track. Never showing weakness. Depression is an evidence of weakness. Very achievement oriented, hardworking type A in many cases, always putting on a brave face and not sharing when you're in distress, and not ever asking for help. So these are all triggers that lead to increased stress and acute illness, and then the symptoms manifest in the form of fatigue, muscle pain, ultimately in difficulty functioning. And so there are some thoughts that then come. If you remember our discussion of panic attacks, you have this physiological response of the autonomic nervous system, and then the individual interprets those physiological symptoms as, I'm going to die, I'm going to lose control, I'm going to go crazy, something really bad is going to happen, that dread that's core to a panic attack. In chronic fatigue syndrome, there is a similar maladaptive series of thoughts. I must be physically ill. This has to be something that has a biological cause, not just stress. I'm making myself worse no matter what I do. That sense of feeding into it, becoming caught in a loop. There's nothing I can do. Helplessness. I should try harder to cope. Excessive guilt, beating yourself up. And I can beat this. The idea that I don't need assistance through interpersonal support. You feel distressed, you feel frustrated, and then you start to avoid activity. You may be oversleeping too much. You may seek medical care that isn't able to help you and leads to more frustration. You may, as they say, put a brave face on things. And then you may have these episodic bursts where you're productive, but in general, consistently, you're not getting things done. And then there's that physiological impact of being inactive, all of that emotional distress that starts to affect all other processes in your body. So there are a few techniques that we utilize in psychology that are psychosocial treatments of physical disorders, things like chronic pain or atrial fibrillation, other things. One is biofeedback. So biofeedback has been around for quite some time, and it's had sort of some rise and fall in popularity, but it's still, a major part of most behavioral medicine practices. What you do in biofeedback is you utilize a variety of simple and complex technology to monitor the body's responses to things. So you have the individual or the researcher essentially you measure things like heart rate, blood pressure, galvanic skin response, muscle tension, your EEG rhythms, and the person is allowed to see that information a lot of times in real time. So you put on a heart monitor and you watch your heart monitor, or you check your blood pressure, and over a period of time while you're doing other things, and while you're talking about these processes, you can measure muscle tension. You have the person subjectively report it, or you measure it through a matter of other techniques. And then, of course, you can have EEG monitors on while it's going on. The idea is that you have this feedback with the person where they're, like, for example, seeing their heart rate. And then you say, okay, I want you to look at your heart rate, see the number, watch the blips, see and understand this is your heart functioning right now. Now let's employ some relaxation. Let's see if we can slow that rhythm down. So that's the feedback process, and you can do it with all different various aspects of physiological reactivity. So the person in real time is able to interact with these measurements and get that increased sense of control and efficacy. So they are starting to feel like, I can do something to cope with this more effectively because I'm actually seeing in real time feedback of me changing this physiological indicator of what's going on in my body. A big part of my job, and a big part of a lot of psychologists' job, is very simple and very effective, and that is helping people to engage with relaxation and a variety of meditative practices. So this can be as simple as just simply teaching the person how to engage their diaphragm and utilize diaphragmatic breathing. I talked a little bit about this technique in the anxiety disorders lecture. Progressive muscle relaxation is a very simple process, usually guided, but you can do it through a lot of apps. You can find PMR or progressive muscle relaxation scripts on YouTube. But the idea is that you utilize some breathing relaxation strategies, and then you sort of go through a process of tensing and releasing all the different muscle groups in the body. And you can go from toe to head, head to toe. You can do it in a lot of different ways, but it's sort of just a meditative process of going through the body and acknowledging and tightening and feeling tension and then releasing tension. Transcendental meditation is a more advanced, meditative technique that's been around since like the 50s and 60s, which is really focusing your attention on a repeated mantra to increase mindfulness, to quiet the mind. Um, you know, Effective relaxation and meditative practices are associated with increased sense of control or increased internal locus of control, feeling a lot more mastery over one's behavior. It can improve things like headache, hypertension, acute and chronic pain. There's a whole host of benefits that we keep seeing from these pretty ancient Eastern practices of meditation and mindfulness. So a lot of times what we find is that the most effective way to help someone who's dealing with chronic pain or stress in their life is kind of a more comprehensive stress and pain reduction program, sort of targeting a lot of different aspects, trying to treat the thing more holistically. So you start off by monitoring and identifying, well, what are the things in my life that are stressful? What are the things that are triggering a stress response? When does it happen? How intense it is? And what are those triggers? You monitor your somatic or your physiological symptoms. You start to sort of get a handle on, when I'm stressed, my body does X, Y, and Z. You utilize these muscle relaxation strategies. You may undergo some degree of cognitive therapy of one type or another. You then work on increasing coping strategies, things like time management, assertiveness training. And what we find is that this sort of holistic approach, this multi-pronged approach, seems to be more effective as a whole than the individual components. There's some really cool research that's done in psychology and treatment efficacy research, where you like deconstruct these complex treatments. So, like, for example, prolonged exposure is a treatment for anxiety. It's sort of the gold standard cognitive behavioral therapy for anxiety, but it has a few components to it. And a lot of times what people will do is kind of conduct a study where you kind of break all the individual pieces up and you combine them in a variety of ways, and you kind of see, like, what are the prime movers, what are the things here that really seem to account for a lot of the variability, the change. And what we found is that for some of these comprehensive programs, the sum is greater than the parts. It doesn't seem to be that one thing is the magic thing that works. It's that the combination of all these factors leads to decreased pain, improved physiological functioning, less distress. This is just an example of self-monitoring of stress. You might give someone sort of a stress diary or a daily stress record. This is just a sample. The person will list the date, the time, and when the stress episode sort of came to an end. They'll give some sort of subjective rating on a scale here you see on the top right of no stress to extreme stress on a scale, in this case, of 0 to 8. They'll identify what the trigger is, a sales meeting, a traffic jam, losing your keys. What were the physiological symptoms? What were the psychological symptoms? So it might be sweating, headache. This person listed impatience, tension, nausea, and then sort of what are the thoughts? So we're getting to the antecedent behavior consequence kind of analysis that we see in behavioral therapy. You want to understand, like, what were the circumstances? When did it happen? How bad was it? What triggered it? How did it feel? And then what did you think? Because really what you're trying to identify, crucially, is really the thoughts in a lot of ways, because that's where we have the leverage to intervene. That's where cognitive behavioral therapy can come in helping the person to identify those maladaptive thinking patterns, to recognize them through mindfulness or more traditional cognitive behavioral therapy, and hopefully reduce those types of thoughts, because they are what maintain the distress. Medication may be prescribed for people that are stressed, but what the research shows is that treating stress with medication, which typically we're talking about things like sedatives, like benzodiazepines, certainly self-medicating with drugs and alcohol is quite common for stress. It can decrease the efficacy of these comprehensive programs, because it seems like the person, you know, medically treating these conditions, or pain medication, for example, can lead to these rebounds. So as soon as the medication is removed, the person finds they were not coping as effectively as they thought, and they get this rebound effect that can increase a sense of helplessness. High relapse rates of these problems when you stop medications, and then of course tolerance for the medications is built over time. For chronic pain is a good example. And so as a result, you know, it's not a road you can just continue to walk down indefinitely. You eventually start to hit ceilings of how much of these medications you can safely be prescribed, how much your body can tolerate, how many side effects you can tolerate. So it's not necessarily as good a solution as trying to address the underlying psychological structures that are contributing to the pain, the stress. So I'm sure that many of you have been told, like, denial is a bad thing, and in many cases denial is an unhealthy means of coping with something. But in certain circumstances, it's not always a bad thing. I have patients who have chronic pain that is not going to go away. There are underlying health issues that are not fixable. They're not curable. They have progressive conditions that are going to get worse. We often talk about distraction, about finding ways to find something else to focus on that you enjoy, whether it's your grandkids or your spouse, so relationship, interpersonal value, or an activity. If you can't do something physically you want to do, what can you do that engages your mind? Can you read? Can you do a puzzle? Can you find a television show that engages you? Can you get up and move around a little bit? Can you pet your dog? Whatever it is. The idea is to just simply, in a sense, exercise a little bit of healthy avoidance. Avoidance as the only tool in your toolkit is not effective, but it is not always a bad thing, especially with a problem that's going to continue to be there on a chronic basis. So, especially in the early stages of the disease, getting a break from ruminating and dwelling on an illness is really crucial. People that are diagnosed with cancer, who may eventually, you know, undergo a cure and be in remission, when they're first diagnosed, that's about all you ever think about, and it becomes very easily obsessed upon and starts to amplify the stress associated with it, and the reaction becomes a problem unto itself. So a little bit of denial, a little bit of healthy avoidance at sometimes can be effective, if only to get your mind on something else and allow you to be present and not so much in your head about the thing that's causing you stress. Ultimately, though, of course, it cannot be the only tool in your toolkit, and you do have to eventually face the situation and process the emotions associated with it fully. But sometimes we need a small break, and that can be like sort of a stopgap technique for someone who is trying to sort of consume and process something really, really large and serious in their life. So we don't always say, like, you have to deal with it 24/7. There are times when it's healthy to undergo a little bit of denial or avoidance, if only to create a little bit of a respite. A big part of health psychology, as I mentioned, is kind of focusing on promoting healthy behaviors, focusing on positive psychology. We have one of the, most world-renowned researchers on health psychology and modifying behavior at Virginia Tech, and that's Scott Geller, Dr. Scott Geller. Um, he is a researcher and a, very big influence in the world of promoting healthy behavior and reducing injury. One of the things that I think is really interesting about Scott is that when I was a kid, there was a television show many of you are probably completely unfamiliar with that was called The A-Team. It was kind of a ridiculous 80s television show, but it was very popular. And it was a group of former military that had sort of fallen into the shadows and were operating, outside of the normal legal world, and they were sort of uh, almost like very positive vigilantes. They would go and help people in situations, and but what's interesting is they had this van that they traveled in, and Mr. T was one of the actors who was one of the main characters, and it was Mr. T's van. He always drove the van. He was sort of the vehicle expert, and what Scott Geller noticed was that on the A-Team that they never wore their seatbelts, and he was like, "This is a show that millions of children are watching, and these guys get in a van, even though, of course, in reality, the van might not be going anywhere. It might be on a closed set, it might be having rear projection, or it might be being towed by another vehicle on a closed road, but they would not put on their seatbelts. And if you go look at movies for decades, they never put on their seatbelts in movies. Only recently does that become something that for sort of a more of a verisimilitude to make it more like real life. You notice people with their seatbelts on. But anyway, the point is that Scott Geller organized a letter writing campaign where children around the country wrote letters to Mr. T and asked him why he did not wear his seatbelt. And the creators of the A-Team listened to these thousands of letters they received. And at a certain point in the run of this show, there's a very obvious moment whenever they jump in the van where they put their seatbelts on. And I thought that was really great that Scott Geller was able to influence pop culture that way. But anyway, he's a good example of how psychologists research and then are involved in public health initiatives to decrease injury. And so we know that accidents are the leading cause of death for individuals ages 1 to 45. So other illnesses start to overcome accidents, but from 1 to 45, it is that is number one thing that kills people. And we know that just warning people over and over is not always effective, that you run up against their ambivalence very quickly when you dig your heels in on one side of an argument. So there are programmatic efforts that can be done to help people engage in healthier behaviors. And this can be, you see this on things like Sesame Street. You certainly see it on back in the 80s again. There was like in 80s and 90s, there'd be very special episodes of sitcoms, which would always be like a sitcom that would have a serious moment where they would talk about something like child abuse or eating disorders, or there was an episode of the old show Family Ties where one of the characters was taking speed for school, and he had like this, he kind of crashed very heavily. But anyway, the point is, there are lots of ways in which psychologists can be involved in trying to promote health behavior. So teaching children how to escape fires or cross the street healthily, to not mess with prescription medication, things like this. So the idea is that as psychologists, we can study how people take in information, how we promote changes in behavior on a large scale, and how those promoted changes in behavior can actually decrease things like mortality from injury. Teaching children not to ever touch a firearm without the supervision of an adult, or poison control initiatives and that kind of thing can all be really crucial in saving lives. One area in which we've seen a lot of behavioral medicine and health psychology play out is in helping people with HIV and AIDS, trying to prevent the transmission of AIDS. Of course, the biggest thing was to promote safe sex practices, the use of condoms, most importantly, sanitary use of needles amongst IV drug users, getting regular checkups, getting tested, and of course, strong peer support programs to encourage people to engage in healthier behavior that makes them at a lowered risk for contracting HIV. Smoking is, of course, as I said, a major, probably the biggest health issue as far as behaviors that impact mortality. China has a particularly big problem with cigarette smoking. It seems, though, to be largely distributed amongst males in China. There's a strong sexual discrepancy between smoking amongst males and females in China. And there's some interesting research in your book where they talk about sort of capitalizing on family structure. So instead of trying to convince or persuade these adult males that were smoking to quit, they developed an intervention program where the children of these individuals were were empowered and given training in how to intervene and hopefully express their desire for the individual to quit smoking. Certainly there's plenty of advertising online and in TV and in movies to educate people about the risks associated with smoking, and targeting those at-risk populations a lot of times, like young people, is really crucial. And so there's been some successful, some not so successful programs intended to do things like promote less cigarette smoking, less use of illicit drug use. So these are all ways in which psychologists help to design and then deliver these interventions on a large scale. There is an interesting study in your book discussed called the Stanford 3 Community Study. This was a large-scale intervention experiment that was looking at reducing risk factors for coronary heart disease. And what they did was they took 3 very similar communities and they compared them to one another, and they essentially created sort of a tiered set of experimental conditions. So they had a control population in one community. These communities were kind of matched based on a number of factors like demographics and socioeconomic status and that kind of thing. And one community got no intervention. One received a media blitz regarding, behaviors you could change, like your diet or smoking, that could hopefully decrease, or weight loss that could decrease your development of coronary heart disease. And the third community received not only that media blitz, but also some face-to-face intervention. So a group of professionals that were trained as part of the study to go into those communities and intervene with individuals to help spread information about these types of behaviors to reduce coronary heart disease. And what they found was that the highest benefit was from the combination of the media blitz and this live interventions that took place. But this is a good example of, this is not the clinical psychology we typically think of, sitting in a room with an individual or a small group of people and doing therapy per se. These are larger sort of public health policy initiatives and research that's testing those types of initiatives to try and change behaviors and psychology, in a sense, on a larger scale to influence physiological health. So to summarize this chapter, let's talk a little bit about the idea that your psychology, your social support network, many aspects of these things that are more abstract, are more subjective, that are not necessarily measurable or can't be pointed to explicitly, they increase your risk for physical illness. And the stress that you're undergoing in your life also increases your risk for physical illness. So these developments of illness are tied to long-standing patterns of behavior and choices that we make as part of our quote-unquote lifestyle, whether it's smoking or drinking or unhealthy eating habits, risky sexual behavior. There are psychosocial treatments that don't just target the individual, but they target their community, their social support network. Sometimes they target large groups of people, like an entire country. And these are meant to sort of sometimes identify at-risk individuals and really zero in on them, but sometimes they're very large-scale sort of shotgun approaches to try and overall change the general trend of behavior in much larger groups. But nevertheless, these are all ways in which psychologists are taking a role in an area that was somewhat closed to them several years ago. So you're going to find, like myself, there are more and more people that don't practice in a stereotypical traditional fashion as you think of a psychologist practicing. Rather, we're embedded and engaged with medical practices, with public and social health policies and organizations, with NGOs or non-governmental organizations, nonprofits. They're involved in media programming and sort of like public marketing in the sense of marketing sort of health behaviors. So these are all ways in which psychology is integrated into a lot of other areas that it really was shut off from in the past. And you can, as you consider the possibility of a career in psychology, if that's something that you're interested in, there are lots of different ways in which you can put that education and that training to work that is not just direct patient care. There's a lot of ways which our understanding of how the mind affects the body can really be harnessed to improve people's health and to decrease the impact of illnesses, including mortality.